Oh, who's your compadre? Short step. Oh, he gets stale. Okay. Just kidding. So I'm David Jones, for those of you who don't know me. What we're going to talk about today is basically acute management of inpatient pain for internal medicine. Okay, the idea behind this is is not to make this a total pharmacology lecture. It was just working.
Turn it on and off.
That's going to suck.
It should click on. Forward.
You got nothing?
Give it a second.
Stop pressing the button. Okay, I'll stop pressing the button.
Okay, I'll see if I can get it working.
Okay, all right. Oh, but this isn't working either. Now let's try it. Okay, cool deal. That's fine. Okay, so, sorry, I like to walk around, but that's not going to happen. What we're going to try to do here is a couple things. Okay, so I guess we should talk about why am I giving this lecture? I don't know, I like pain stuff, it's not fun, okay, there's lots of fascinating things. What we're going to try to do here is understand, what exactly pain is. Okay, some basic kind of pathways behind it. And then what we're really going to try to concentrate on is reviewing guidelines that do exist for the management of pain, acute pain on the inpatient medicine service. Okay, which up until recently there's been absolutely nothing to really give us any guidelines on this. And since we're in the era now of opioid concern, it makes this an important point. We're going to emphasize basically multimodular therapy, narcotic minimizations, and we're going to review some very basic concepts of kind of opioids. My goal is not to make this a pharmacology lecture, okay, but more of a practical, how do we actually do this stuff, right? It's not to say that the pharmacology isn't a ton of fun, it's just that's not necessarily real useful. Okay, so I'm going to tell you right now what I'm going to tell you. Okay, and we're going to revisit this as we kind of go along. So, in addressing any kind of inpatient acute pain scenario, the very first step is to assess pain, okay, which is basically characterization, location, severity. All right, the second step, which we often don't necessarily do very well, is to think about the factors contributing to the patient's perception of pain. Okay, this is something that's known as the psychosocial pain model, okay? And these things just briefly, also include stuff like anxiety and mood disorders, insomnia issues, maladaptive coping mechanisms. These are all the things that make this frustrating for us as providers and often make it hard for the patients. We're going to discuss a little bit the characteristics of opioids and some of the stuff that you need to know, even if I'm not going to beat you to death with the metabolic pathways of opioid breakdown and the different receptor subtypes. Okay, we're going to review what is now the current guidelines out there. Okay, we're going to talk a little bit about how do you actually interact with people when you're actually at the bedside working on, how is your pain. Okay, we're going to talk a little bit about, again, multimodal therapy, which basically includes scheduled medications, NSAIDs, adjuvant medications. We're going to talk about escalating to lower the potency of the drugs that you choose, and a little bit about duration. We're going to talk a little bit about tapering opioids and all-in analgesia, and really kind of, I want to emphasize that in many ways, as weird as it is, it doesn't matter as so much about the direct agent that you are using or the agents you're using. It's kind of about how they perceive it, okay, which is a weird thing. Now, one thing I will tell you is we often want to think about, addressing and treating acute pain as a one-size-kind-of-fits-all. Wouldn't it be nice? Let's look at the order set, like the medicine admission order set. It gives you those nice kind of breakdown things, and we can just click those little buttons and off we go. Well, that just doesn't work, really, okay? And there are better ways to do this. Okay, so let's start with the basics. What is acute pain? So acute pain is basically nociception. Nociception comes from multiple peripheral receptor types. There's all sorts of them, and they basically detect a potentially damaging or noxious stimuli or insults. This process of nociception is basically 4 modes, okay, transduction, transmission, perception, and modulation. This is a dynamic process. It is not a static process. Additionally, and this is just, those of you that have been with me have heard me say this before, you can basically divide pain into 3 general characteristics, right? So the classic somatic types of pain, neuropathic pain, and what is my totally unofficial existential pain, okay, which really captures a lot of stuff and is really the area where we often struggle. All right, so let's just review just briefly the different levels because it's useful to think about this. Okay, so what is transduction? So basically transduction is stimulation of nociceptors, okay, which are basically free nerve endings in various types of receptors. There are 2 main pain afferent types of fibers, C fibers, okay, and basically delta fibers. So C fibers are everywhere. They're all over. They're slow. They're not myelinated. Okay, they give you, when they're stimulated, essentially those dull, aching, non-specific pains. Okay, versus delta fibers, where truly this is they detect a direct mechanical and thermal stimuli. They tend to have a higher threshold of activity, faster conduction time, and this is what gives you these sharp pains. Multiple immune and inflammatory substances can alter the receptor stimulations and their set points. These include things that you should be familiar with, things like cytokines, neuropeptides, substance P, COX-2, proteinases. All right. This hopefully looked a little bit familiar to you from some textbook. So this is basically transmission. So the next step after transduction of a stimuli is basically transmission of that stimuli. So the transmission of the stimuli, once you have activation of the peripheral receptor, sends through the peripheral afferents to the spinal cord nerves, which then relay it up to the brain. If you're talking about head and neck, that all passes through the trigeminal nerves. The trunk, visceral, and extremities basically travel through the afferents to the spinal dorsal horn nerves, where there is a intersection. The afferents coming in basically release multiple excitatory neurotransmitters, and there's a couple things that can happen here. So with this kind of interface, because everything is about the stimuli coming in, repeat stimulation, okay, at this portion of the horn basically causes sensitization over time, okay? It's kind of a process that's known as wind up. Additionally, long-term kind of C fiber, again, that slow, non-specific kind of dull conduction, over time develops this tone where this kind of stimuli keeps activating and these nerves in the dorsal horn keep going and keep firing even after you've removed the noxious stimuli. So these 2 kind of nerve, spinal cord processes combined with a kind of loss of a descending stimuli, which will give you what's termed central sensitization. Okay, and this is kind of helpful and to think about because a lot of people that we work with often have chronic pain, which is based off of a central sensitization process. Okay. So transmission and modulation, again, these are just the basic sets, the basic processes of the nerve pathways. So descending pathways often come down to the spinal column or down the spinal column to the dorsal horn. Okay, these descending pathways can be both excitatory and inhibitory. Most of the stimuli that we talk about, this is inhibitory, and these are modulated through things like gabapentins, enkephalins, endorphins, serotonin, noradrenaline, oxytocins. And this is kind of a feedback loop that the body uses to kind of control the strength of the stimuli and how much pain you're having. So why is this useful to look at? Well, so if you look at some of these things in this descending inhibitory pathway, you start to see places where some of the drugs that you're familiar with are going to act, okay? So for example, right, descending pathways using serotonin and norepinephrine, so drugs that do that, okay, that you know for pain management, things like SSRIs, TCAs, SNRIs, tramadol has serotonergic activity, methadone has serotonergic activity. So this is where some of this activity is actually taking place. You know, enkephalins and gabapentin, again, or GABA, you know, in the interneurons causing an inhibitory tone, also can be augmented by common stuff like gabapentin. All right. So that's just kind of the basic pathways behind it. What's the next thing? So what really, where we tend to struggle with acute pain management in the inpatient is often the idea of how people perceive their pain, okay? And so there's a number of things here. So the perception of pain is not straightforward. So case in point, from one person to the other, people have very different experiences of pain. There is no real absolute way to measure it, right? And so this diagram here kind of gives you just a taste of all the different centers in the brain that are actually involved in the perception and of pain. Okay, and out there, there's this idea of how do you describe this? Well, you describe this as the psychosocial model of pain. And basically that encompasses everything, all right? It's, what is your, coping mechanisms for experiencing pain? What is your anxiety level for experiencing pain? What is your fear of pain? What is your, background in how much degree of control do you feel that you're going to have over your pain? All these things all are involved in how individual people experience pain, okay? Which sounds like a lot, and it is a lot, okay, but it is useful to kind of think about these things as we try to treat acute pain in patients coming into our inpatient services. So if you kind of break down this perception of pain, and there's a number of kind of fascinating neuropsychiatric studies and papers that kind of look at this. You can kind of think about everyone when they get confronted with a painful stimuli or a painful situation has a number of neurocognitive areas or ideas that influence how they perceive their pain. So one is attentional, okay? And so what this is it's truly, how much attention are you paying to the pain, okay? Because I'm sure most of us at some point have gotten distracted and you've injured something. You'll notice that when you're not paying attention to it, it's not really as painful. And this is a very real thing. It's also what they call the kind of the perceived threat of pain. How much, how fearful are people about having pain? And there's a wide range of how people view this. These fears are based off of just fear in general, fear of pain, poor coping mechanisms, poor adjustment mechanisms, increased levels of anxiety, and catastrophic thinking. Okay, what is your expectation? Are you anticipating that you're going to have a lot of pain? Because if you anticipate that you're going to have a lot of pain, you are going to have a lot of pain. Okay? And then also, what degree of kind of what they call readjustment? How much control do you have over it? So regardless of what I give you for your pain, okay, if I do it in a way that makes you feel that we are addressing your pain and controlling your pain, okay, you are going to have less pain. Okay, if I'm doing it in a way where you don't feel that I am adequately adjusting your pain or addressing your pain, you're going to have more pain. Okay, and so things like placebo in pain is actually a really real thing. And again, this is where some of these fun studies come in. Okay, like for example, okay, if I give you there's one kind of fun one where basically they gave people red pills and they gave people blue pills. Okay, any idea which colored pill had better pain control? The blue pill. Okay, why? I don't know. That's just what it is. Okay, and so this perception is a very important thing in how we handle this. All right, so let's talk a little bit about the elephant in the room, which is opioids. Okay, and again, I'm not going to beat you to death with opioid pharmacology or chemical structures or breakdown products or those kinds of things. This is what we all get to, right? This is what we think of as often pain management and what patients often come in thinking about as pain management. All right, so what's the deal with opioids, right? There are a bunch of studies out there that basically say that opioids are not necessarily any more effective in pain control than Tylenol or NSAIDs. So why do we do it? Right? Well, opioids are complicated medications, and so if we pause and we think a little bit about the activities of opioids, they're kind of a pain bomb, all right? And so if you look at people who have opioid addictions, why do they like them so much? Well, so if you actually talk to heroin addicts and opioid addicts about the very first time that they ever did an opioid, they will also often give you a story that goes something like, I took the medication and suddenly I was encased in a golden light of wonderful feeling. Okay? Well, that's pretty good, right? So I did this kind of search, on the internet, looking for, graphics and images that try to depict, just the effects of opioids. And it's, I used to be able to find this stuff. I couldn't find it anymore because now all I can find are the ones that are trying to scare people, which is good because they are scary medications. But people are using them and want them because they make you feel fantastic. Okay? Or at least they have the potential to, right? And they fix your, anxiety, they can help you sleep, and here you are in the hospital, and we don't let anyone sleep, and we never tell anyone what's going on, so everyone's anxious. If you go back in time, in history, you can pull up stuff where, laudanum was used to soothe crying babies, and, all this other stuff, help people at home, with a whole variety of different malaise and injuries and problems, because it just, it gives you the euphoria, and that is an insanely powerful, potent thing for a very large portion of the population, right? Opioids themselves, well, so they modulate pain sensitization both on the central level and in the peripheral level, and so they do have analgesic effects, okay, and so they are analgesic. But again, what we all know from just practical day-to-day is that's not the part that we struggle with, okay? Now, you've all been through I'm assuming your, opioid safe prescribing town hall, so you also know the background about how we've actually, we as global physicians did create a large portion of this current mess, right? But in any event, what we're talking here is how are we going to use these medications? And so my takeaway for you is that these are complicated medications, and when you're actually prescribing them, remember, okay, they're not any better than anything else for actual analgesia necessarily, okay, but they do help with a whole host of other related symptoms, which do tie into that perception of pain. All right, so just because, this is we'll talk on how we actually do acute pain management on the inpatient level. Okay, we do need to be, even though I'm not going to beat you to death with pharmacology, we need to be aware of a couple concepts, okay, just for using opioids. So first, Has anyone, who here has heard of narcotic opioid equivalence tables? At least most of us, I hope. Okay. So just to highlight these issues about the use of narcotics. Okay. So all opioids basically can be converted based off of their potency into what are called morphine equivalents. And you use this morphine equivalents when you're changing between different forms. Okay, now a lot of times we don't do this, okay, but you absolutely, for much higher doses, and particularly in chronic pain management, you do a lot of this. There are a multitude of these charts out there and available, so if you actually have a question about this and you're actually making adjustments in opioids, you want to at least be familiar with these references. There are some problems with, the opioid equivalency charts. Does anyone know how they make these, how they calculate these? How do you figure out if one opioid is more potent than the other? Huh? There you are. Okay, you give them one, you say, how does your pain score go? You give them a second one, and you say, well, how does it compare? Okay, what's your pain level now? So there's a lot of stuff that goes into these, and so there is some fluctuation and variation in different opioid conversion charts. The ones that, I just pulled up the one here from Up to Date, plus a couple, one other that I kind of like. These are reasonable. There are a number of things based off of genetics, individual things that will alter and affect this, so it's not an absolute, but it is a good guideline to be familiar with. Okay. Another concept to think a little bit about with opioid medications, okay, is duration of activity. So every different narcotic and type of narcotic has a different relative potency, but it also has a different relative duration of activity. And so again, if you're giving someone and you're attempting to use opioids for, a pain control, and you're scheduling their pain medication at Q8, or giving it at Q8, but the duration of activity is only every 4 hours, only 4 hours, you're going to have trouble. So again, as you go forward and we talk about some of these medicines, I want you to think a little bit about, what is the duration of activity of individual agents. Okay. Now, actually finding the duration, it used to be a lot easier. I've noticed that a lot of the charts have actually started to drop duration of effect, at least some of the ones that I saw. And so, I found this chart, and this gives you a rough idea of duration of activity of a number of different agents. Now, I will tell you, again, there are factors here that affect this, okay, and factors that change this. And so I kind of wrote in next to them a couple of the ones, and all these durations that are listed in this red box are kind of extra liberal, I would say. And so they don't usually practically work at these durations. All right, so what kind of stuff changes how people do with, what duration of the medication lasts, particularly with the opioids? Well, so all sorts of things, right? So stuff that you can think of normally, like opioid tolerance based off of prior exposure to opioids, a concept known as opioid cross-tolerance, okay, which is based off the use of other drugs, other substances, usually depressants, okay, which are particularly alcohol is a common one. So what does this mean? It means that these people will have higher narcotic requirements just based off of the fact that they drink regularly. Okay, increased metabolism. This can be due to the ingestion of using other medications, either prescribed or not prescribed. The genetics and individual receptor subtypes for people. Things that increase duration of the medications, so impaired hepatic metabolism due to cirrhosis or some other hepatic insult. And then the one that you should just kind of remember, which is specific to morphine, which is morphine 6-gluconoride, which is the morphine active metabolite that you will at some point be tested upon. Okay, so with that stuff kind of briefly mentioned, let's talk a little bit about how do you actually approach acute pain scenarios. Well, so there's been something that's been around for quite a number of years, which is the World Health Organization's Analgesic Ladder. And it's not a hard concept, okay? It's basically you start with low potency stuff and you escalate based off of response till you find the minimal potency agents that will work for someone's pain, okay? So Is that what we do? No. Not particularly. Okay? I found this cool chart, which I really like, which gives you an idea of opioid strength comparison. So the 0 point there in the middle is basically morphine, and all the rest of this are the different analgesic agents arranged based off of potency. And of course, since I'm giving the talk, the one that I highlighted there was my least favorite medication, which of course is Dilaudid. Okay, and so we'll take a moment to make a plug for not using Dilaudid based off the idea that why are you starting at the top of your potency spectrum? Okay, it doesn't correspond with any particular guidelines to the treatment of acute pain. Okay, so with that being said, let me also make a little plug here for why I hate Dilaudid and you should too. Okay, so beyond the fact that Dilaudid is a very high potency medication, it is almost practically indistinguishable from heroin. Okay, and so there was this really cool study out there that basically took a look. Well, it's not really cool, but I guess it's cool. So it basically took a look at the utilization of Dilaudid as part of a heroin replacement program. So has anyone heard of heroin replacement programs? So the UK's done it for a really long time. Okay, Canada has one clinic up in Vancouver, though they did, I think, earlier this year, sign legislation to basically make it across Canada. So what this basically is this is for heroin addicts who are the worst of the worst. They fail abstinence therapy, they fail methadone maintenance therapy, they fail Suboxone therapy. Okay, and so what they actually do is they give them heroin. Okay, and so these people actually come in and they inject heroin in a clinic, twice a day, sometimes 3 times a day, and they go on and they go to their jobs and they go home and they do that stuff and they come back every day and they keep doing it. And it actually, allows them to stabilize their life, and it works as a medication-assisted therapy, and it's pretty good. Now, again, what are the difficulties in getting, medical-grade heroin? Well, they're, reasonable. So they actually they took a look to see what other medications they could use for this, and they found that Dilaudid actually works great. So if you take, they took about, I believe it was a couple hundred hardcore heroin addicts, and they blinded them, and half of them they gave Dilaudid to, and half of them they gave heroin to. And they asked them at the end of 12 weeks, okay, which drug did you get? And you know what? These guys couldn't tell the difference. So it's just not a fantastic choice. Okay. The other issue is if we think about not just the potency, and so you're starting at a high potency agent, which does not go along with any kind of treatment regimens. It also has a very short duration activity, and so we start running into problems there too. All right. Sorry, I couldn't resist not putting that in there. Okay. So what are we going to talk a little bit about now? So this is kind of the meat of what we need to go through. So until this last year, there really were no guidelines or consensus statements available or out there for the treatment of acute pain in the inpatient general medicine population. Okay? This last spring, the Society of Hospital Medicine put together a group, a task force that basically released a statement trying to offer some guidance to how we approach acute pain in the inpatient setting. All right, so not that you can necessarily see these or read these, but essentially there's a whole series of recommendations, and we're just going to kind of go through a number of these just to kind of talk about some of the ideas behind these. So you can divide these recommendations basically into a pre-opioid prescribing and a post-opioid prescribing decision tree. Okay? And so what they're basically suggesting is that in all patients coming into the medicine services who are coming in with an acute pain issue, we think about and we proceed in a particular fashion. So in general, okay, the general recommendation is that we try to minimize the amount of narcotics that we're actually using for analgesia, okay, for a number of reasons. Okay? They cite here, of course, the multitude of adverse effects, okay, and largely the fact that in numerous studies, there really is no clear-cut analgesic benefit to opioid medications versus non-opioid medications. Okay, and so basically the consensus statement is a trial, at least when people come in, of non-opioid therapy before we actually escalate to opioid therapy is reasonable. Well, so, okay, is it reasonable? I don't know. We get these admissions, right? And people come into the hospital and they say, I'm having the worst pain in my life. Okay, this is absolutely awful. Is it reasonable to give them non-opioids? Right? So this is a JAMA study from 2016, which basically is based out of an emergency room, and this guy has done a couple of these where he basically looks at people who come in an acute setting to the emergency room for different pain scenarios. Okay, and then he basically divides them into groups. Okay, and he says, okay, this group, all these people coming in, and this one is acute upper extremity pain. Okay, so basically non-specific, all comers across the board, acute upper extremity pain. Right, and he divided them into four groups. He gave one group ibuprofen and acetaminophen. He gave another group oxycodone and acetaminophen. Another group hydrocodone and acetaminophen, and the final group codeine and acetaminophen. Okay, and so in the end, there was absolutely no difference between any of these groups. And so that's significant, because what that means is, what we're doing with all of these opioid medications is not necessarily beneficial or even necessary, right? And so it gives validity to the idea that, we can in fact give ibuprofen and acetaminophen as a first-line therapy for any pain complaint. Okay? Now, all right. Recommendation 2, again, a pre-opioid recommendation. So it basically says that, when you proceed and you are thinking about giving opioids for someone for a pain control issue, you need to think about all the factors that actually influence that. Okay, and so these things are, age greater than 65, renal insufficiency, hepatic insufficiency, COPD, emphysema, obstructive sleep apnea, co-current medication uses, and any history of, drug abuse and drug addiction. Okay? Now, none of these things are necessarily absolute contraindications, but these are actually major medications, and so you need to at least think and contemplate and usually document why you are doing what you're doing. One of those recommendations that is just the way the world is now is everyone needs to review the prescription monitoring program here in Ohio. Okay, you have to do it because it's basically law here in Ohio, but it is actually a very useful thing because it will give you a sense of what kind of medications people have been on, what other concurrent controlled substances they're using, and how you can expect them to actually do as they go through their pain experience. They make this also general, recommendation number 4, which is you need to educate people about the risks of the utilization of opioid therapy. I don't know, has anyone ever done this? I'm not sure I've ever done this. Okay, I'm not sure it would necessarily be very, very helpful, but it is a recommendation. Right. All right. So, if again, with this idea of both the World Health Organization and then this hospital medicine, initial therapy for pretty much all pain across the board could potentially be something as basic as Tylenol and an NSAID. Okay, and if that is not effective, you can certainly escalate. Okay, but the places where you should be escalating is, again, the pain is not adequately controlled. Okay, it's a terrible, severe pain. They have some piece of metal sticking through them. They're going to need some higher level of analgesia. Okay, and once you actually make that, the goal here is still to use the shortest the lowest dose effective opioid for the shortest possible duration. Okay? So what kind of opioids are we talking about? Right? So does anyone know, can you tell me what some lower potency opioids are that we have here and commonly use? Codeine. Yeah, we don't use it much, but you could. Okay? What else? Tramadol. Sure. Okay? Those are great places to start. Okay? You know, you do not have to go directly to oxycodone. You do not have to go directly to hydromorphone. You can actually start with these medications and titrate up. And again, how can you do this? Well, keep in mind, and does, I guess we should say, how can you do this and does this actually work? The answer is yes to both, and you can do both. And why is that? Well, you remember those red pills and those blue pills? Okay? That actually, again, plays a huge component in this. Right? And so for what we're dealing with in the inpatient medicine services, you know, it may not actually be entirely what the agent you're using, but how you're doing it. And so when you're actually promoting this and saying, I'm going to be putting you onto these medications, I'm going to be putting you onto Tylenol and ibuprofen, and they roll their eyes, and you're going to say, well, we're going to be scheduling, and we're going to have something for breakthrough medications, and it's going to be, tramadol, okay, and we're going to be, kind of monitoring and adjusting as we go forward. That actually works for people, okay, because it's the act, it's giving them that sense of control and that you are actually addressing their pain issues. Okay. All right, we gotta speed this up. Okay, so just in the back of your minds, they also make a recommendation that in general we avoid long-acting narcotic formulations. So these are things like Oxycontin, MS-Contin. And I think this is actually fairly appropriate in general for most comers. For what we of the patients that we have, there are a few cases where those medications are in fact useful for acute inpatient management. But as a general rule, you just don't even want to go there. Okay. All right, this may be my ultimate favorite recommendation of all these, okay? So use the oral route, okay? One of the biggest problems that I see over and over again is we get into these cycles where we're using IV narcotics. Well, why is that? Why do people like that so much? I don't know, because it makes you feel frickin' fantastic, okay? So there's absolutely no reason to use IV medications short of they literally can't take anything by mouth. They are truly vomiting everything that passes their lips, okay? And to be frank, even then, you'd be surprised at the ability of people to tolerate narcotics if they have a desire to, okay? But the truth is, this is a much better route for analgesia. Why? Because all of the opioid medications, if we're using opioids, okay, and pretty much all medications, have a much longer duration of activity. Okay? And so in a lot of ways, it's kind of like insulin dosing. All right? Think of it as, you're trying to give them a nice, steady background state. And you do that by basically dosing the medications in a longer duration route. Okay. I'm going to skip that. All right. This is one of those very important points here in these recommendations that basically says you want to use a multimodal therapy. So what do they mean about multimodal therapy? Okay, so multimodal therapy is basically Tylenols, NSAIDs, okay, in addition to any kind of minimal, the lowest potency opioid you can, plus additional adjuvants. Anyone know what adjuvants are? What kind of medications are adjuvants? So stuff like, besides Tylenol and NSAIDs, gabapentins, okay, gabapentins, TCAs, topical medications, lidocaine topicals, all these other medications are all adjuvant medications that you can use on top of things, okay? The other part of this multimodal therapy is you want to be using scheduled multimodal therapy. Now, I have a slide in here coming up that basically I took as a screenshot out of, again, your order set that you see on your admission orders. All those admissions, all those medications that are on the analgesic order set are basically PRNs. Does that work? No, it doesn't work, okay? And there's a whole host of reasons that it doesn't work. It is much better to actually schedule medications, which means you're going to have to change the orders in the order sets. And this is a firm kind of recommendation. You want to schedule things like the Tylenols, the non-steroidals, and all these other adjuvant medications. So why is that important? Well, again, it comes down to that perception, okay? And so the surgeons do a lot more research into acute pain management than, say, the medicine people. And so there's a whole number of these kind of studies, which actually, strangely enough, are based mostly out of OB-GYN, okay? And they take a look at how do you treat post-operative pain, okay? And so this study, for example, looked at post-cesarean section, I believe was this one, yes. And they basically did two things. They said, okay, we're going to schedule your medications. We're going to be scheduled Tylenol, okay, and maybe a dose of something like Toradol, okay, and then we're going to give you PRN narcotics, or we're just going to give you, again, PRN narcotics, that you can ask for when needed. And so what happened? Well, so the group that got the scheduled Tylenol had better pain scores. They used fewer narcotics, and they were overall happier with how their pain was actually being addressed, which gets us back to this perception concept, which is they perceived their pain as being better controlled. Okay? Whether it was or not is totally moot because they thought it was. Okay? And so the scheduling of these other medications, it makes some pharmacological sense, right? So if you're giving people medications, you want to maintain a even or near even therapeutic levels of these medications to maximize kind of the effects of them. The other thing that they saw in this, which supports that, is patients who receive scheduled medications had more benefit from additional doses of their scheduled medications than people who are using just PRN, with the idea that it was actually increasing because you had a higher baseline concentration. Okay, that being said, please remember that Tylenol is associated with 20% of liver failures in the U.S. All right, so let's talk just a little bit here about gabapentin. So gabapentin is another major, kind of adjunct medication. I use a lot of it. And for a while there, it looked like it was going to be really great. Has anyone heard in the news about gabapentin prescribing in the United States? So after we went into kind of the opioid crisis, there was a huge spike in gabapentin prescribing. Okay, probably because we had all these chronic pain patients on opioids and we didn't know what else to do with them. Right, and so we put them on gabapentin. Okay, and there is some validity for these medications. Gabapentin really does work, and it appears to work at increasing opioid sensitivity. Okay, and how do we know it does it? Well, in, again, pre-surgical, studies, if you dose people with really high doses of gabapentin, pre-operatively, you can reduce their post-operative use of analgesia, narcotic analgesia, somewhat. Okay. It has a really great effect on anxiety also. So, but it does seem to be helpful, and so we can use this as an adjuvant medication. But the reason that it's no longer, or it's not really the end-all answer, as in we should put everyone on gabapentin, was this particular issue. And so last year this came out, which basically says that when we give gabapentin to people with heroin addictions and opioid addictions, they die. Okay, and which is, I guess, a statement that says that yes, gabapentin does in fact increase opioid potency and opioid effects because they're dying more. Okay, but it also limits, how we can use this. Okay, quickly, opioids recommendation number 10 for the Journal of Hospital Medicine: use bowel regimens. Okay, and recommendation 11, which is also a very important recommendation, is you need to limit co-administration of opioids with other CNS depressants, specifically benzodiazepines. Okay, and then probably another important one, which is 12, which is recommends that patients and families and caregivers work to establish realistic goals. So since we are out of time, let us skip ahead. Okay, so what might a multimodal therapy look like, and how does this interaction go? Okay, so this would be an idea for you about what multimodal analgesia for virtually any pain issue coming inpatient might look like. Okay, and it's actually pretty darn effective. Okay, and it is not necessarily in your order sets. And it does work quite nicely to decrease overall opioid use. And so this is something you can keep in mind. Now, the other issue, because since we know that this is pain, how does this actual initial encounter go? So, when you walk into basically the room and you say, okay, I'm here to do your HMP, and tell me a little bit about your pain. Okay, one of the things that you need to kind of contemplate is how bad is the pain, and get a sense of, how am I going to communicate to them that I'm going to work with this. And so, actually using things like the pain score is really useful. You guys, what's the pain score you know? 0 to 10, right? Okay. How accurate is that? How many people here routinely get pain scores from patients with 5 on their initial assessment? I would guess not many, because the ones I have are usually 9 and 10, right? And so, just as a practical thing, it is very useful, and actually there's data behind it, of resetting in your communication, this pain score. Because one, it helps them know that you're actually going to be addressing their pain, which again feeds into their perception of how things are going. And so how do you reset that pain score? Well, depending on the person, you got to tailor it a little bit. My favorite is, let's see here. Michelle, how's your pain today? Pretty good. Pretty good? Pretty good? Okay. All right. Well, so, if, for example, someone comes in and they say, I've got a pain of 9 out of 10, you need to reorient them a little bit to what does that mean. Okay, so my favorite is, so let's talk about it. 0 is no pain. Okay, 10 is I've lit you on fire. You remember those monk protesters to the Vietnam War that put themselves on fire in the street? That's a 10. Okay? I may not say that to the little 9-year-old babies, but something equivalent. Okay, and what happens there is what you get is a reset of usually the correct answer then is they'll come back to you and say, okay, well my pain is really a 7 or an 8. Okay, and then you can actually work with that. And in this very initial, as you're getting this information, the other thing that you need to tell them right away is, listen, my goal is not to erase your pain. Okay? I am not getting rid of your pain whatsoever. Always. If I do that, I'm giving you too much medications. What I want to know, now that you've told me your reset reasonable pain level of 7, is what would be a tolerable pain level for you. And you actually get a lot of insight into people when they tell you what their tolerable is, because some people say, oh, it's still a 0. Well, then you're in for a bad ride. Okay? If they come back and they tell you, I can tolerate a 3 or a 4. Okay, I can do that. You bet. I can take you from a 7 to a 3 or 4, but that's really what we're targeting. We're not targeting 0. Okay, and that is just the message that you reiterate, and by doing that, you give them the perception that you are addressing their pain and it is more control. It doesn't necessarily matter which agent you're using, okay, as long as you're giving them the perception that you're doing it. All right. That'll be it. Okay. Questions, concerns, you all have to go. Yes?
So you told us so many times that it doesn't even matter what we are giving. It just matter how we phrase it and whatnot. So why are we giving opioids anyway?
That's a really damn good question.
Why do we just stop doing that?
They don't use it in a large portion of the world.
I think one reason is we must have to become an internet IV. Because you get stuck. Not many times, like the patient comes in, they have taken these 4 or 5. And you can't give them any benefit. And I come from the UK before, everyone calls it the 90s paracetamol. You don't use opiates as much. But here, if the patient has kidney disease, and multiple patients do, then you're stuck with opiates. You don't have an option. They vomiting, they're sick, they have taken 4 or 5. Yeah, I'm sure that more than one patient like this, like say, a couple of weeks, I wouldn't have given them opiates at all. But you force. The unpaid, it's subjective, you can deny that, something.
So here's the interesting thing about IV acetaminophen, okay? And so it's one of those hot topics right now, okay? And there's lots of literature, and pain literature sucks, let's be frank, okay? The quality of pain literature, the actual research behind it sucks, Okay? And so you can find 50 studies that say that IV, Tylenol is the next best thing after sliced bread. Okay? And you can find 50 studies that say it's absolutely useless. Okay? So where is the answer? I don't know. Okay? I won't tell you the pharmacists here aren't getting it for us, so we better think of something else because they say that you can still get Tylenol by rectum. No, I've never done it. But there you are. Okay? So no, why are we doing opioids? Dr. Rosenberg, who you may know from Outpatient, told me a couple of years ago that he has a letter in his office somewhere from the State Medical Board of Ohio that basically says that he was underprescribing narcotics, okay, and that he was probably neglecting his patients because he wasn't writing enough of narcotic prescriptions, okay. So that just gives you a little evidence of just how weird the world actually is, okay.
What year was that?
Oh, God, that was probably 1995-ish or so. When did we start doing the study? It was 99? I think it was 99. It's around there. Okay.
When I was in residency,
right.
97, 98.
Yeah,
Not to date myself, but yeah, we were told we were undertreated all.
Yeah, I mean, you almost can't appreciate it now, and it hasn't been that long. Okay. The actual pressure to prescribe opioids was insane, and it actually came from a single opinion piece. No data, okay? It was an opinion piece that basically set the whole, set the stage for the liberalization of narcotics to non-cancer pain, okay? And it exploded from there. Why? Because they make you feel freaking fantastic, right? And that's what it comes down to. So no, you do not need to use opioids. Why do we use them? I don't know. They work great on battlefields. I mean, I'm going to assume that you've seen Saving Private Ryan, right? Okay. Well, this is what we're talking about. One of those medics slamming into those guys' thighs. They're slamming in ampules of morphine. Why are they giving them morphine? Because it shuts them up, it makes them feel better, okay, and they're dying anyway on the field. So no, when you actually look at comparative effectiveness, there is no difference with narcotics. And to take it even further, there's actually no data that narcotic doses above about 25 milligrams morphine equivalents per day do anything more for you. Right? Nothing. In fact, all that you really see is a escalation of miscellaneous side effects. Right? So how do you square that? I don't know. Right? But the message for going forward from here in this era of we don't want to use narcotics is, limited. Okay? There are ways to do it. You can do it. It is a validated method. You do not have to use these. In fact, you should be doing something else than just prescribing narcotics as your first go-to. Does that make sense? Anything else? Okay. Thanks for toughing it out.
Dr. Infeld did? Oh.